listeners. I'm Taylor Cordum, and I am a technical trainer on Allina Health's Learning and Development team. I work with Allina Health employees to help them learn the workflows that are essential to their new jobs. And today, I'm here to help you learn some easy-to-know, yet important tips about breast cancer. In today's episode of Talk with a Doc, we are joined by Dr. Jasmine Camboj, who is known for treating her patients like family and is much loved and admired by her patients and staff. Welcome.
Thank you, Taylor. Thanks for having me here. So just a wee bit of my background. I'm a medical oncologist and hematologist at the Allina Health Cancer Institute, and am here today to address all of our questions with regards to breast cancer awareness. I believe that every patient is a human being first before they are a cancer patient, and I love to treat them that way. And besides being a clinician, I'm a very strong advocate for patients about cancer concerns like prior authorization in oncology or screening programs in rural America. And I'm routinely involved at the Capitol Hill in Washington, D.C., and locally here in the states of Minnesota and Wisconsin on such issues.
That's amazing, Dr. Camboj. Thank you so much for joining us here and providing your expertise to our podcast today. So we are here to learn a little bit more about breast cancer. Breast cancer is the most common cancer in women in the United States, with estimated new cases around 290,000 and estimated deaths 44,000 for the year of 2022. Fortunately, screening leads to early diagnosis and hence better outcomes. Today, we are going to be talking about a fictitious patient, Fina. She is 37 years old and is concerned about when to start screening as she has a strong family history of breast cancer. So, Dr. Camboj, could you please shed some light on Fina's concerns?
Yeah, absolutely. And that's a great question to start with, Taylor. That's because the data with regards to commencement of mammography is all over the place. And mammography or any screening tool is the one most important modality to improve outcomes in any cancer, and particularly in breast cancer. So I decided to kind of stick to two basic recommendations from two major societies or groups. One is the American Cancer Society, where a woman who has an average lifetime risk for breast cancer could get started with mammography at the age of 40 years annually, and women beginning the ages of 45 onwards should get annually screened with mammography. After the ages of 54, they could get annual or every other year mammography. And unfortunately, there's no clarity on when to stop doing mammography, but in general, it is recommended that we should continue with annual mammography at least as long as they have a 10-year life expectancy or more than that. And just for the sake of clarity, when we say lifetime risk is average for a particular person, that kind of entails categories as follows. A woman is considered to have an average risk if she has no personal history of breast cancer, no strong family history of breast cancer, no genetic mutations that are known to be associated with breast cancer like BRCA1 and 2, and has had no chest radiation before the ages of 30 years. The other group that I wanted to kind of touch base with was the NCCN, or the National Comprehensive Cancer Network. And for a woman who has an average lifetime breast cancer risk, NCCN recommends that at the ages of 25 years, every woman should have a clinical encounter with clinic breast examination every 1 to 3 years, along with breast awareness. And what the word breast awareness means is basically just knowing your own breasts and periodically doing self-breast examinations. The self-breast examinations also have 5 different steps to themselves. So basically, you sit straight in front of the mirror and evaluate visibly how your breasts are looking. You evaluate on the grounds of symmetry, any skin changes, any kind of obvious changes. Then you raise your arms as the step number 2 and look for any kind of asymmetry or lumps or masses. The third step is that you look for any kind of nipple discharge or nipple changes. The fourth step is that you lay down on the bed or wherever, and you take your right hand and you feel for your left breast, and you take your left hand and feel for the right breast. When you're trying to self-palpate your breast, you're basically doing a superficial breast exam to look for the skin changes or any kind of findings. And then you press harder against your rib cage to do a deep breast exam and make sure that you cover all of your breast tissue, whether you like to go in circles or from top to bottom. So that is what a breast awareness or self-breast examination entails. And at the age of 40 and above, NCCN recommends that we should increase the frequency for clinic encounter and clinic breast examination to an annual visit at least. The screening mammography starting at age 40 is a category 1 recommendation by NCCN, which means it's based on very high level of evidence, and there is uniform NCCN consensus that this particular intervention is appropriate. And when available, 3D as opposed to 2D mammography is recommended.
Wow, Dr. Camboj, that's so much helpful information. Thank you so much. So you did mention a lot about mammograms, and our fictitious patient Fina has heard that there are different kinds of mammograms. So could you explain the differences between 2D and 3D mammograms?
Absolutely. And again, that's a very that's a very routine question that we get a lot in our clinics as well. So, just to give a background, United States has approximately 50 million mammographies being held every year. So that's a big number. When we say 2D mammogram, what that entails is that the patient's breast is being evaluated in two different angles. One is from top to bottom, and the other one is from side to side when the x-rays are being taken. Whereas a 3D mammogram or a digital breast tomosynthesis is a kind of mammogram where there's a machine that basically takes low-dose x-rays while it moves in an arc sort of way around a person's breast. And therefore, as you can imagine, there are a lot more images being taken. A computer then consolidates these images and hence allows the radiologist to see the breast tissues in much more depth in 3 dimensions. 3D mammography has proven itself to be better than 2D mammography when it comes to evaluating more dense breasts, finding more breast cancer, and definitely it has a lower callback rate. There is currently a clinical trial to compare 2D versus 3D mammography called the TMIST trial. The word TMIST stands for Tomosynthesis Mammographic Imaging Screening Trial, which is basically an NCI-funded trial that is trying to figure out the answer to the question whether 3D mammography is truly reducing a woman's risk of developing a life-threatening or advanced breast cancer compared to 2D mammography. So the end of the study is expected to be in the year 2025, and I'm very excited to see the results of this trial.
Yeah, that sounds great. I would really like to see the results of that trial as well, being a young woman myself. So very interesting information to come. So Dr. Camboj, Fina, our patient, undergoes genetic testing, and she was found to be negative for the BRCA1 and 2 mutations. Do you want to comment on MRI as a screening modality?
Absolutely. So generally speaking, MRI is used as a screening tool when we are wondering about a high-risk breast cancer patient. Which means that a particular woman's risk of breast cancer in lifetime is more than 20% as defined by models based on family history, or they have a five-year risk of invasive breast cancer more than 1.7% in individuals who are 35 years or older for a Gale model, or these women have had thoracic radiation between the ages 10 to 30 years, or they have had a diagnosis of high-risk breast lesions like atypical ductal hyperplasia or atypical lobular hyperplasia or lobular carcinoma in situ. So these are the categories where we would use MRI as a screening tool as well.
Great. It's nice for patients to have so many options. So let's talk a little bit about how a breast cancer diagnosis could impact a patient's life. So a few years later, Fina, our patient, gets a mammogram and they find a lesion that is suspicious for being cancerous. What would those next steps be for her?
Yeah, so it's really good to talk about them because it kind of gives our audiences and our listeners a kind of run through as to what to expect when something this unfortunate might happen. So first of all, I just want everybody to be aware that there is a village that comes together when it comes to a cancer patient, and definitely when it comes to a breast cancer patient. So unfortunately, if the mammogram shows a concerning lesion, most imaging centers, and definitely at AHCI, we would have the radiology section schedule further steps, which would include a diagnostic mammogram, which means that we will do an in-depth analysis of the lesion more thoroughly, plus minus MRI based on the radiologist's recommendation and this particular person's lifetime risk of having cancer, followed by a biopsy. Usually it is a core biopsy that is done in the imaging center itself. And once the biopsy report is out, which is obviously read by a pathologist, once the biopsy report is out, then appropriate referrals are made to two oncology groups, a surgical oncologist who is going to be the surgeon who would take care of the patient, and a medical oncologist who would be the person responsible for making assessments and management with regards to systemic treatment, whether it is chemotherapy or endocrine therapy or immune therapy. A lot of the patients are also discussed at multidisciplinary case conferences. And what that means is that the case conference is basically a group of doctors and other ancillary services that come together and discuss the cases and just come up with the best recommendations in context of the national guidelines.
That sounds like an amazing opportunity for all of our providers to get together and come up with, some next steps for our patients. So that's a great tool for you all to have. Mm-hmm. So let's say that Fina feels overwhelmed after her biopsy and she's a little worried about future consults with different doctors and care teams. So you mentioned earlier that a cancer patient is, brought on with a village, their village of doctors. So Dr. Kamboj, could you address what that village might be?
Yes, absolutely. So first of all, that doctors are only one part of that village. They are one minor part of the village. I would say that there is a nurse navigator who basically orchestrates all the next steps for this particular patient, and who's also usually the point of contact for the patient. So with regards to any of their questions or any of their concerns, our nurse navigators all across Allina are doing a phenomenal job with regards to addressing their questions, concerns, and guiding them through the next few steps appropriately. And so basically, they would be visited by a surgical oncologist and medical oncologist after the case conference discussion. Based on their other circumstances and their risk and family history, etc. Other ancillary services come into role as well, like a nutritionist or a geneticist. If we have younger patients, unfortunately, and we do have some young patients, there's always a fertility expert involved in their care as well. And then, of course, if needed, based on the stage of their cancer, a radiation oncologist would be a part of their care as well. So just wanted to say that the patient is not by themselves. They are definitely not alone. And it's a bad thing to have. It's an unfortunate event to be diagnosed with cancer, but we do try our very best to make them feel comfortable and address their questions and concerns in a rightful fashion.
I'm sure that's very reassuring to patients in such a scary and unpredictable time. So Fina has been on nutritional supplements. Our patient's been on a multivitamin. She's been doing iron and B12 supplements. She also takes vitamin C pills when she gets a cough or a cold. Can she continue to take these supplements while she goes through her breast cancer treatment?
I'm so happy that you asked me this question, Taylor, because, just a few years ago, there was an eye-opener trial. And in this study, patients were questioned on their use of supplements because, we would assume in our minds that use of supplements should be associated with good outcomes or better outcomes because we feel more replenished. However, the results of the trial were surprising to all of us. So what we found was that use of any antioxidant supplement like vitamin A or C or E or carotenoids or coenzyme Q10, both before and during treatment, was actually associated with increased risk of recurrence and possibly death. Vitamin B12, both before and during chemotherapy, was associated with poor disease-free survival and overall survival. Similarly, use of iron before and during chemotherapy was associated with recurrence. Multivitamin use, however, was not associated with survival outcomes poorly. Therefore, after the results of this particular study were out, all of the medical oncologists have stopped recommending routine use of these supplements along with chemotherapy. The only supplement that is okay is multivitamin, as it was not associated with poorer outcomes.
That's really good to know. Thank you so much for giving us that information. So Fina is towards the end of her treatment journey now. She has successfully undergone surgery, chemotherapy, and radiation therapy. She's now being started with surveillance. She wants to know what she can do to obtain the best outcomes and minimize her risk of recurrence in addition to the medical treatment that she will be receiving. So Dr. Camboj, what would you recommend to Fina?
Yeah, that's a great question, Taylor, because as much as we'd like to, treat the cancer, we want to minimize the chances of its recurrence. And there's actually a lot of good things that we all can do to minimize our risk of having a recurrence. So the NCCN, which is National Comprehensive Cancer Network, as I mentioned earlier, suggests that active lifestyle, healthy diet, limited alcohol intake, and maintaining an ideal body weight with BMI between 20 to 25 leads to optimal breast cancer outcomes. And I'll kind of pick and choose a few of these things because there is strong data, there's robust data to prove some points here. So for example, the ideal body weight and a healthy diet, which may entail fruits, vegetables, etc. So with regard to the BMI, poorer outcomes were seen in obese patients independent of treatment factors. And obesity is actually set to take over tobacco use as the leading cause of preventable cancer-related deaths. And if the current trends continue, obesity is going to be attributed towards more than 500,000 additional cases of cancer each year in the United States by 2030. Unfortunately, unlike tobacco use or cigarette smoking, our populations are not very well educated about this particular issue. There was a survey that ASCO, one of the national societies in oncology, did in 2018, and we figured that even though 80% Americans knew that smoking cigarettes is a risk factor for cancer, only 35% were aware that obesity is actually also a major risk factor for cancer. So that just calls out for a lot of educational awareness with regards to obesity and trying to obtain an optimal BMI between 20 to 25. The other point I wanted to make here was consumption of tree nuts. So there have been now two clinical trials kind of highlighting the use of tree nuts and kind of impacting cancer outcomes in a positive fashion. And I'll just elaborate on the one that was done in the breast cancer world. The other one was done in the colon cancer world. So the breast cancer trial was actually published in International Journal of Cancer in February of 2022, where folks were assessed at 5 years after the diagnosis with regards to nut consumption. So people, the trial itself had around 3,500 breast cancer survivors. So as you can imagine, it was a good, robust trial. So it turns out that the folks who were routinely consuming nuts as a part of their diet had higher overall survival, 93.7% versus 89% in the non-consumers, and disease-free survival, 94.1 versus 86.2%. So definitely there's something in the nuts which is helpful for minimizing our risk of breast cancer recurrence, and definitely in our health in general as well. The last point under the lifestyle category that I wanted to bring up was alcohol consumption. It turns out that International Agency for Research on Cancer has classified alcohol as group 1 carcinogen, and breast tissue is particularly more susceptible to the adverse effects from alcohol consumption. So we got to minimize our alcohol consumption and have a good exercise-based lifestyle.
That's really great information and a lot of great tips, Dr. Camboge. Thank you so much for all of that. You mentioned alcohol is a group 1 carcinogen, though. What does that mean? I'm not quite familiar with that.
Yeah. So group 1 carcinogens is the category where we have sufficient evidence of an agent with a causal relationship for cancer in humans. And International Agency for Research on Cancer considers alcohol to be causally related to breast cancer risk. So for example, there is a 7 to 10% increased risk of breast cancer with each drink consumed daily by an adult woman. So even if we are consuming only 1 drink per day, equating approximately 10 grams of alcohol intake, that increases our risk for breast cancer by 7 to 10%, both in premenopausal and postmenopausal women. If we are deemed to be light alcohol consumers, that risk goes up to 4 to 15%. And every year, we have approximately 9,000 to 23,000 new breast cancer cases that are attributed to alcohol consumption.
I didn't realize that. That's really good information. Thank you. So to kind of sum up what we've talked about today, what would be one takeaway point that you have for our listeners?
Yeah, and I tried to put it up in a very simple fashion, and I came up with 3 S's as the takeaway point. And 3 S's meaning self-awareness, which entails self-breast examination, self-accountability, which means, being responsible for your health in general and keeping up with the recommendations of societies, and screening. And again, that comes down to the mammography. Early breast cancer it has got really good outcomes. The survival outcomes almost more than 95%, which is great. And that can be achieved only if you yourself are involved in your own care and start with the screening processes early in your life. Thank you.
Well, thank you so much for joining us today, Dr. Camboge. It's been great having you here and being able to access your knowledge and expertise. So we really appreciate your time.
Wonderful. And thank you for having me. And thanks to our listeners and definitely most importantly to our patients and families. Thank you. Thanks, Taylor.
During this episode, everyone, we discussed a story about someone who was caught off guard by a breast cancer diagnosis. While there are definitely hereditary risks, there are also many risk factors that are under your control. And just as importantly, doing self-exams and getting screened regularly will help you catch breast cancer as soon as possible, which gives you the best chance of a speedy recovery. Thank you to our listeners and most importantly, our patients and their families. And remember, if you have any questions, just talk to your doc.